Morning, everybody. Welcome to another patient summary call in what might not be the best weather, but hey, thankfully the cyclone's slowed down, so I'm still chairing the meeting for you. We did have backup plans, but we haven't had to enact them. And I'd like to start with an acknowledgement of country. We acknowledge the traditional custodians of the lands on which we all gather today. For me, that's the lands of the Turrbal and Yagara peoples. We pay our respects to elders past, present, and emerging, and extend our respects to all Aboriginal and Torres Strait Islander people. And we acknowledge the First Peoples as the first scientists, educators, and healers. So we've got a bit on our agenda today. We've got usual business that we always do at these meetings, approval of past minutes, going over any updates and news. Then we're going to come back to our use cases and use case approach. And Shelley's going to present that on an approach on how we're going to keep going through that throughout this project. And then we're going to do a report back from the last meeting, which was actually the face-to-face workshop in Adelaide, which was amazing. It was fantastic to be in Adelaide for the first time for me in ages, but also for us to come and do a face-to-face there was just fantastic. And there were so many people, and it was such a great discussion. So we're going to have a report back of the patient summary conversations and workshops that were there. Then I'm going to go through and do a patient summary exchange options exercise. This is going to be a cut down version of the workshop that was done face-to-face. And we want to come back and do that for this regular call and kind of have a look at what that means when we're having, I guess, more of the technical conversation. And for those people who weren't able to join us in Adelaide, and finish off with what's next. And what's next in terms of also our next meeting, which is a hybrid one that's part of the Sydney Trans-Tasman HL7AU Symposium and Connectathon, and also talk through the Connectathon. So that's our agenda for today. I'll just double check. Is there anything else that people think we need to add to the agenda? Any burning topics we need to get talked about this morning? All right, hearing nothing, let's move on. So first up, usual business. And we want to approve the minutes. So we've got two to approve. We've got the last call we did, and that was on the 7th of February. So I'll just go to that. So this has been out for review for quite a while, actually. And so there's no outstanding feedback on this. We've got, the YouTube link to this, the slides, we've got the motions that we've got here, and some detailed minutes on what happened. This is the meeting we did the walkthrough of the FHIR IG. So that's all in there. Now, does anybody need any more time to review this? Hearing none, would someone like to make a motion to approve the minutes of the 7th of February?
I'll make a motion, Danielle, Tim, from the agency.
Thanks, Tim. Would anyone like to second?
I'll second, Steve Swinsburg.
Thanks, Steve. Just about to put up a poll for approval of the minutes. So that poll's there. Please vote affirmative if you approve these minutes, negative if you don't, or if you think you need more time. And if you weren't at that meeting, feel free to abstain. If you've dialed in and don't have the chance to select one of these poll buttons, you can just say your name and say what your vote is. Okay, so that's come through now. I'm going to close that in 5, 4, 3, 2, 1. I'll end that poll and share the results. Steve, can you confirm what your vote is?
Yeah, +1, and there's also +1 for Tim because we're both
okay.
There first. Yeah.
No worries. So with that, we have 14 affirmative, 0 negative, and 13 abstain. That motion carries. The minutes are approved. So let's just pop back to these ones. Then we've got these minutes. Now, these haven't been out as long for review. So this is from the workshop day. I think they came out a bit over a week ago. And incredibly extensive. Big thanks to Shelley and Maddie for the work they did to help capture all the discussions on the day. So what we'll find in these is the slide pack from the entire day. There's also transcripts of all the worksheets that were filled out are off this link here. You will find all the mentees that were put up and their results are on here, and all the detailed discussions that happened throughout the day and who reported back is on here. Now, does anybody need any more time to review these before we look to approve them? Heath?
Weren't these approved yesterday in the TDG?
Yes, this is a joint one between both AU Core and Patient Summary, and so we're giving both calls the opportunity to identify if there's anything missing in the minutes or if we're happy to call these done.
So we're approving the entire set of
Yes.
minutes. Okay. Thank you.
All right, if no one needs any more time, would anyone like to motion approval of these minutes?
I would like.
Thank you,
Ilya.
Ilya. Would anyone like to second?
Landon Riley, happy to second.
Thanks, Landon. So I'm just going to pop up the poll again. I'll relaunch that. So same poll, please vote affirmative if you're happy to approve, negative if you need more time or you don't agree with something in the minutes, and abstain if you weren't there or haven't had a chance really to review the minutes so you can't make a decision. Still waiting for a few more people to vote. All right, I'm going to count that down in 5, 4, 3, 2, 1. I'll end that poll. Steve, Tim.
Yeah, we're both +1 it's in the chat.
All right, fantastic. So that makes the affirmative 14, 0 negative, 14 abstain. That motion carries. The minutes are approved in this call. All right, so with the usual business out of the way, for at least for the minutes approval bit, let's get back to this. So there were no documented actions coming out of that we're tracking at the moment out of the last couple of minutes, but we do have some updates. So in the yesterday's AU Core TDG, we did agree on a proposal for the AU Core medication statement profile. So that's actually gone into the AU Core FHIR IG yesterday, and the changes will be flowed on to AU Patient Summary pretty quickly, actually, because that has some impacts into the Connectathon snapshots. So for the Connectathon coming up, we're trying to get the snapshots for that published as soon as possible. Now, BASE has been published already, so you can find the AU BASE Connectathon snapshot. It's published as 510 preview. AU Core got published last night, and it includes the medication statement agreements in it. So that's published as 110 preview. And Patient Summary is coming. I think that's probably more like Monday next week. Well, hopefully Monday. I think that really depends on the cyclone and network and power as to whether it's a Monday or later in the week. Other update. So our next meeting, which is part of the Trans-Tasman HL7AU Symposium and Connectathon, is a hybrid meeting. So part of that is face-to-face and part of that is hybrid. So if you can't join us face-to-face, there are connection details. So the invites for that have been sent out. We're at a little bit of a different time here. So that's 1:45 in the afternoon till 3 o'clock is the time slot we've been scheduled on the day. This will also be recorded if you can't make either in person and you can't join us online. This will still be recorded and made available as part of the minutes and up on YouTube. Now, you should have got these invites. So if you haven't received the invite and you think you should have, can you please let me know? either by emailing me, or you can contact me through Zulip, which is chat.fire.org, and send me a message, and I'll try and track that down for you. All right. The other thing I wanted to note here, and Steve, can you pop this in the chat, is there's a Zulip poll out trying to look at dosage and which parts of dosage are being used in Australia. This is something that I think that we also want to respond to with respect to patient summary, because dosage elements are flagged with must support both in IPS, and they'll be flagged in AU Core. And so I think that's something we want to feed into around what's being implemented in systems, what information is available. So there's a quick poll here. It's on Zulip, and I'll just go to it now. Because I'm subscribed, I think it'll jump to the end, but wow, that's taking a while to load. All right, everyone should see this now. And if I scroll up, you can see there's 3 questions here, which if you're on Zulip, you can just answer with multiple choice by selecting the option. And if you could contribute to that, that would be really helpful in terms of shaping some of what the AU Core decisions are going to be around dosage, and making sure they're also working for patient summary. All right. Any questions, sorry, about the Zulip poll? Okay, let's move on. Last update is there's an EOI that has been popped out quite recently. We did some really successful testing events last year, where to support some of the development and some of the implementation of AU Core last year, we held a couple of small events in between the HL7AU connectathons. And there's been a lot of interest to continue doing that this year. And also to look at doing that now that we're doing AU Core is also saying that really our different standards projects aren't meant to work in total isolation here. Core is an upstream specification that flows into patient summary and requesting, and it looks at core digital health data. Patient summary and e-requesting have some potential links, and we've looked at that in our consumer journey. And putting out essentially an expression of interest to understand if there's any interest in doing that again this year, and doing that around June, July, so in between the connectathons, and where and how, like which city would you be interested in testing in. So based on that, we'll look at scheduling some events. If there's any interest to do that, there'll also be opportunities to test outside of events as well. And we're asking if people are interested in that, and whether or not we need to focus a bit more as well around testing outside of specific events. So it'd be really great if you could reply to the EOI and kind of tell us, what are you interested in, to help us shape out what we want to do later on this year. All right, at this point, I'm going to hand over to you, Shelley. Would you like me to keep going with the slides and you just tell me next slide?
Yeah, that'd be great. Thanks, Danielle.
All right.
So good morning, everyone. So today we want to talk about proposing an important addition to our FHIR implementation guide, and that's dedicated use case pages. So use cases are a set of informative pages with examples that help a reader to understand and implement the AU Patient Summary FHIR IG. And so what we want to get done for today is, just to give you some framing, we've had some background meetings in the last couple of weeks, and now we're bringing the outcome of those meetings to the group. So what we want to do today is work through the addition of our use cases to the AU Patient Summary FHIR IG. The aim for today's meeting is to agree on an approach for how we're going to go about that, and also to agree on a list of initial items for inclusion when we document a use case, so that we can go away and we can start creating some drafts for those pages, knowing that we can always come back later and add some more. And then there's also going to be a review, there's going to be ballot. So there's going to be heaps of spots where people can raise suggestions and feedback if they want to. But also warning you that if you do raise a suggestion, we are going to ask you to come back and put some work into that as well. So Yep, next slide. So we just got a quick recap of our R1 use cases. So we have our interstate GP visit, which aligns with the patient-driven patient summary. We have our emergency hospital attendance, which aligns with the clinician-driven patient summary. And then finally, we've got our referral to specialist and allied health, and that aligns to our clinician-driven patient summary as supplemental information. So just a little bit around governance and decision making. So the clinical focus group are going to make the decisions around clinical workflows and context, ensuring that the patient summary use cases align with clinical best practices and workflows. However, they're not going to be involved in the technical implementation decisions unless we need to consider clinical impact. And then the technical design group, we're going to make decisions around the technical implementation decisions, the FHIR IG structure and content, and just ensuring alignment with FHIR standards and managing technical feasibility considerations. And this is what we're going to be doing in these fortnightly calls. And again, just reiterating, this is what we already do with our governance and decision making. So we're just continuing on with that with our use cases. Next slide, please. Okay, so I want to walk you through the approach we've taken to develop the AU patient summary use cases and highlight the steps that we need to align on moving forward. So let's start by having a look at the work that we've already done leading up to where we are today. So back at the start, we began by engaging members of the digital health community through a series of scoping workshops. And these workshops gave us the insights into key requirements and stakeholder perspectives. And then following these workshops, we synthesized the insights, and then we went away and drafted the initial consumer journeys, just making sure that we captured a broad range of patient and clinician interactions with the patient summary. So then we took those draft journeys and brought them back to the Spark Clinical Focus Group, and we had some further discussion with them. And this was really key in validating some of our assumptions and refining those journeys with clinical input. And then based on the feedback that we got from them, we took those away and made some refinements. We added some new consumer journeys where we needed to. And we just made sure that we had a really comprehensive and representative set of scenarios. And so we sort of, went through that process a few times. We take them away, come back and get some more feedback and take them away and come back again. And then we finalized those consumer journeys. So now that's set the foundation for the next phase of what we'd like to do, which is translating those detailed use cases into our FHIR implementation guide. So if we shift our focus to where we're going next, this is the approach that I'd like to get alignment on today, and that's this blue section here on the right-hand side. So the next key step is ensuring that we've got clear agreement on the key design decisions for each use case. So this includes things like defining interactions, the data flow, making sure we align with national and international standards. And once we've agreed on those initial design decisions, then we'll go and incorporate them into the draft AU Patient Summary FHIR IG. And this is going to be an iterative process so that we're going to go away and come back again to you guys for some more design decisions. And then we'll go and draft again and come back again over and over the next few weeks. So we'll aim to have a pre-ballot review around June, and this will be a crucial opportunity for us to gather some early feedback from stakeholders and address any gaps before we go ahead to formal approval. And then finally, our goal is to move towards formal approval through the AU Patient Summary ballot process, and we'll address any feedback that comes up as part of that process. So in a summary, we've done the groundwork. Now we're focusing on formalizing those use cases and integrating them into our FHIR IG and getting ready for approval. And so what I'd like to do today is confirm with you guys if this approach aligns with your expectations and if there's any other key considerations that we need to factor in before we move forward. Next slide, please, Danielle.
There's a couple of points that I'd like to make on this.
Sure.
In terms of the use case design decisions discussed and agreed, that's going to be these fortnightly calls. And that will also be looking through and addressing the feedback. That will be brought back to these fortnightly calls. If anything about that changes the design decision, such as when we talk about whether or not something is, direct authored or if it's generated and then curated or those kinds of things. And the same thing will also happen through the ballot and addressing feedback, that we're going to bring that feedback back to this set of calls to talk through about whether we want to change any of what we've put into the use case of the use case examples.
Lovely. Next slide, please.
I'll just also, before we move on, just double check. Does anybody have any questions about the approach?
Daniel, just about the process, is there a conference page for people to provide inputs while the process is rolling on?
Yes. So at this point, as soon as a design decision is discussed and agreed, we'll keep the approach here is to continue elaborating in the FHIR IG. I think that's around the decision of so some of the major points which Shelley called out are really around saying if we're going to do the example for like the emergency hospital admittance, there's a whole bunch of things that we need to go, well, if we're putting that example in, we've got to make a few decisions and we're going to come to this call and make those decisions and then update the sequence diagram and keep coming back to these calls. So the use cases will keep being elaborated every couple of weeks. So they're going to continuously change. And the documentation is going to be reviewed at this point. But as soon as they go into that IG through the continuous integration, obviously that means they go into the continuous feedback cycle of the IG, which has that specification feedback in it. We've got the milestones, of course, both at June and the milestone that goes through ballot, which is actually 2 ballots. But of course, everything we do will be visible and brought back continuously, both to discuss in here, and then people can make comments through the specification feedback process. Does that address that question, Stephen?
Yeah, partially, but I was thinking that having the draft IG and the iterative process is good, but it is kind of depending on fortnightly meetings like this, but in between, if people have inputs, is there a mechanism for people to sort of review the artifact in development, not necessarily looking into the draft IG itself, and then provide some commentary or inputs to that. One thing that I thought about is that with a conference page that captures the content about the information that's being pulled together, be also a useful medium for the in-process type of input rather than the fortnightly kind of interactions and discussion. Just a thought, doesn't have to be that way. If we consider that a fortnightly meeting is sufficient for the discussion collections of the requirements and then do the CI build, and that's fine. But I'm just thinking that in between, when people have a bit of downtime and want to have a look at it, and through the contents that is being developed, in particular the use case diagrams, is there a platform for people to provide kind of written input, which we can then take to the fortnightly meeting? But it's not
probably. I think I'm concerned about maintaining a Confluence form of the exact FHIR IG page. I mean, I guess we could just copy paste what's in the FHIR. Like, so I think there's the as proposals are put to the fortnightly calls, they often take the form of Confluence pages that are put out for review beforehand. That might be the case for those things. But in terms of the current state of the use case, because it is the use case that's in the FHIR IG, the current agreed draft will always be what's in the FHIR IG. So we maintain that approach of the current draft of agreed things in this call are in the FHIR IG. We could,
that's fine. Yeah,
if people want to copy that every time we push up to the FHIR IG and copy that page and then copy and paste it into the Confluence over the top of things. But I don't really want to double handle and I don't really want to draw people's attention away from the patient summary FHIR IG as being the community agreed current draft of patient summary content.
Yeah, that would be fine. As the process evolve, we might sort of make adaptations. Just the questions of
Yeah.
I thought as to are there a sort of other platform that can help the process as well, but it's not
Just before
necessary. Yeah.
just before we go to sevens, I mean, we have both got the current draft of the consumer journeys and the technical use cases and storyboards were reviewed through Confluence. And I think this is how do we get out of Confluence and into our actual FHIR IGs with real FHIR examples that are actually built in the FHIR IGs against the profiles. I think that's really the approach we need to get to now, is taking it out of a pure documentation sense and into the implementation guide itself.
Okay, that's fine. Yep, thank you.
Yeah. Sevens?
Hi. Sorry, it's Sue Evans. I'm sorry
Oh,
about
Sue.
that.
Okay, I just
That's all right. My fault. Getting used to Zoom. I'm the director of the Victorian Cancer Registry, and we receive a lot of data from health services, and a lot of our HIMs are taking data out of the patient summary. And so this is my first time at this meeting, but I am keen to understand what are the data elements within that summary, and will it be applicable for the data sets that all of the jurisdictions need to report through to their respective cancer registries as part of their legislative kind of requirements. So where do I look for that? Are you able to provide us with a summary of what the data fields will be, so that we can make sure that they are complete?
Now, let me double check who's on the call. Can Shelley or Steve, can you find a link, please, and drop it into the chat? Because what Sue needs is the AUCDI. So it's the logical model that identifies the data elements that are relevant to patient summary that they're starting with. And that was published for review. I think that was published for review about 6 weeks ago. And I think I think they might have come out to your organization as just identifying that this is available for feedback. Now the feedback is closed, but it would be really good if you have any further feedback to provide that in. And in fact, what I think is best, because I think that's really looking at the logical data elements and the relationship back into clinical best practice, which is absolutely what the clinical focus group and clinical design group are working on and are working through. And I think I'll pop it into the chat now, sparked at csiro.au, because I think we could get into a call with you and specifically discuss your needs. And I see Shelley's popped the link there for the logical model that will identify those data elements and how it relates into the clinical content.
Yep, fabulous.
And so that's
we are looking at sort of
work.
developing this as a national registry as well. So I think that now is the time to make sure that we've got the data sets set up. So I'm not sure, but I'll probably also involve a couple of other people from registries into that call as well. But that sounds fabulous.
Fantastic. And so part of what we do in these meetings is we have the clinical design group and clinical focus group, as you see on the left, who are providing that clinical context on what are those high priorities. Here's how we see the consumer's journey through healthcare and the points at which a clinician will need to see this data or access it. And we take that information into our calls. And what we try to work through is how can we support those use cases through FHIR. FHIR is the technical exchange standard. And so we look at how do those data elements map into particular FHIR resources, what kind of interactions do we need to implement and make available, and then look to provide some examples. And so that's part of what we're doing now, is we've got the drafted consumer journeys, and we've got a very high level use case, and we're about to work through in the fortnightly calls in more detail how will that look like in FHIR, and which example might we put into the IGs, because at the moment, and this has been very intentional, both the consumer journey and the technical use case has been quite agnostic to some technical decisions. and to end up with an actual example use case with this system calls this other system and it uses this kind of data exchange format, we need to get a little bit further. And that's what this proposal is saying. Let's come back every fortnight and let's actually make some of those decisions and go, hey, for the emergency hospital admittance, we actually think that's a patient-authored patient summary. I mean, maybe it's not, but there's a whole set of options we're going to say, well, this is the example we'll put in the IG so that that can help other people who want to implement this standard understand how to use it. And that's really what we're driving at here.
Thank you. That's really informative. Yep.
All right. Are there any other questions or things that people would like to talk through about the, I guess, the high level kind of approach for this? And if not, I will finally go to the next slide, Shelley. Sorry about
All good. No, all good.
All right.
Okay, so what are some of the things we can put in our use cases? So again, we'll work through that through the TDG to define what goes in there, but some of the things we could potentially put in there, we could put the actors involved. So your doctor, your patient, your pharmacist, your healthcare system. We could put in some workflow steps, so we could illustrate key interactions and data exchanges. We could put in some relevant FHIR resources, so defining how profiles, operations, and terminology fit into the workflow. And we could also put in some applicable UML diagrams. And we've got some links there to some of the other use case specifications that we had a look at. Next slide, please. So the thing that I want to emphasize here is that the use cases we're presenting here, they're just examples. They're not mandates for release 1. We don't want to get stuck debating specific implementation details too early. Instead, what we're doing is we're using these examples to illustrate concepts and workflows. So we know there's multiple different ways to achieve the same outcome in FHIR, whether we're using $summary or $.ref or both. And these are the type of decisions that we're going to work through together. So some of you guys might remember in previous discussions where we focused too much on the storyboards rather than the broader framework. And what we want to keep in mind is that elaboration is a key part of this process. So we start with the general consumer journey, and then we refine it into an example. But that example is not the final word on implementation. It's just a tool to help guide the discussion. So at the end of the day, we're here to refine the use cases in a way that provides useful guidance without being overly prescriptive. So if we set the right expectations now, we can keep our discussions productive and focused as we move forward. Next slide, please. So this is some of the stuff that we think might be useful to start with. So these are some of the proposed initial inclusions that we could put in our use case documentation. And the framing for these use cases is that they're going to help people understand how to implement the IG. So we thought it would be useful to include a use case description, which would provide an overview of the use case, what it's about, the problem it solves, and its relevance within the patient summary framework. It might be useful to include the actors. So the actors are the people or the systems that interact with the use case. So this could be patients, clinicians, healthcare systems, or external services that exchange data. We could add some preconditions. So they define the necessary conditions that have to be met before the use case can be executed. So for an example, a patient's got to have an existing record in a healthcare system before their summary can be accessed. For post conditions, they describe what should be true after the use case has been executed successfully. So these could be things like a referral being generated or a patient summary being successfully retrieved by a clinician. We've got sequence diagrams, so that could be UML diagrams, and they're good to make it clear how interactions occur. They illustrate the step-by-step flow of the data and the actions between the actors. And then finally, we've got our FHIR resource examples. So to bridge the gap between concept and implementation, we provide concrete FHIR resource examples, and these just help technical teams understand exactly how the data should be structured and exchanged. So at this point, I'd like to hear from people, which things do you think would be particularly helpful out of this list so that we make sure that we don't drop them? Is there anything here that people think is unhelpful? Is there anything we've missed? Is there anything that people find really useful that we haven't included? So we'll go to a Menti. So if everyone can get their phones out or go on their computers and jump to menti.com and enter that code, we'll get the feedback directly. I'll just give you guys a few minutes to scan that QR code or get that login code, and then I will share to Menti. All right, so if everyone's had time, Danielle, are you happy for me to go into the Menti now? Yeah.
Yes, I am.
Fabulous. So hopefully everyone can see that Menti on screen. Yep.
And hopefully I typed the right numbers and didn't transpose any like I did the other day.
They're up the top, so hopefully you guys can see them. Okay, so everyone, hopefully everyone's in. We'll go to the first question. Oh, got in there. So which of these do you find most useful? So down the bottom there, we've got use case description, actors, preconditions, post-conditions, sequence diagrams, fire resource examples. So if you can vote for multiple, you don't have to just pick one. And then there'll be an option at the end to add any in that you think are additional that we haven't got in this list. So don't worry, you'll still get a chance to add in any that are missing from this list. We just want to get an idea, sort of in order of importance, what you think is most useful for you when you're looking at an IG. Give everyone a few minutes.
This is a separate thing, but I also have to work on those colours. I'm not appreciating the salmon.
I'm sorry. I am colorblind, so I'm sorry. You get
no, that's okay. I think we just need to go back to primary colours somehow instead of the mauve and salmon and burgundy.
It'd be good if we could get some sparked theming kind of colours too.
Oh yeah, I think that's possible. I'll have a look at that for our Menti account. But I just reckon the greens, the blues, the yellows, the reds is easier for people than, I don't know. Yeah.
I must admit, I think these are the default ones. So we've got 22 responses. Does anyone need a little bit more time or happy to move on to the next one? Yep. Still getting some through.
Yeah, there's 21 people have replied.
All right, I'll count down from 5, 4, 3, 2, 1. Okay, we'll go on to the next question. So of this list, are there any that you think are a bad idea or not useful, or that you wouldn't, you're not less inclined to include? Or everyone's happy that they think they're all useful things that we would like to see in there? I should have put an option for no, they're all fine.
So just a question about the examples. Is that within the IG or generally, or specifically around the use case descriptions within the IG?
Specifically around the use case descriptions in the IG, but they would actually link to the real form of them. We could share screen on what that looks like. So taking the approach that's been in other FHIR IGs, where you see that, like the Gender Harmony IG has the examples, but those I think are practically V2 rather than FHIR, but yes. So the use case page would talk about the actual and show in a code window FHIR, the actual FHIR, the JSON.
All right, I'm not seeing a lot of action here, so I might count down from 5, 4, 3, 2, and 1. Oh, one last week. Someone got in there last minute. Okay, we might go to the last question then. Okay, so there's anything in addition that you would, anything in addition to the set that we've proposed that you would find helpful. So feel free to add in anything you think that we haven't got in that list that you'd like to see, or that you think would be particularly useful for yourself when you're implementing. Everyone's perfectly happy. Looks like we nailed it first go, Danielle.
Hang on, I'm typing. Give me a
or
bit.
the Menti's not working.
No, I'm still typing because I'm on my phone.
Okay.
And it just takes a bit of time.
All right. Well, while we're waiting, more examples. while we're waiting, I'll just say to all of our participants that are in Queensland, I hope you're all safe and dry and stocked up and ready to go. I myself am sick of just waiting. I just want it to come already. So yeah. Technical exam, more examples, more use cases. Yeah. More diversity in example. All good points. Business diagrams.
That was me.
Ah,
Oh. Yeah, I tried to use more words than is allowed. I think we might need to
Oh.
edit that because I was going
Yep.
to say exactly what I meant by that, but
yeah.
the character
Do you want to
limit cut
elaborate,
off.
Danielle?
I do. So I think it would be, I liked the fact that we had storyboards or the consumer journeys that provided a pictorial view of the narrative. I think the sequence diagrams are actually crucial, but I think it might also be helpful to have some very high level graphical of what steps are being shown.
Yeah.
Yeah, I agree with that. I was thinking it would be part of the description, but yeah, so probably more detailed than the journeys, but I was almost going to use the UML term activity diagram, but
Yep.
I think because of the broad range of people we expect to pick up and read this, some of whom will gloss over the FHIR resources and sequence diagrams because that's not really what they're reading it for. I still think that it would be very useful to see a graphical thing that's more tailored at maybe BAs or product owners or that kind of thing to help.
Yeah, we've
share. Yeah.
yeah,
got a few
workflow
workflow
diagram
diagrams in there. So
perfect.
yep.
Mm.
Yep. Well, that's good to know.
But I'm still totally for the UML. This thing is transitioning from the clinical thing into the FHIR, which the sequence diagram I think is my pick for that, showing part of the RESTful API.
Yep. Okay, so we've got 15 responses. I'll just give it a few more. Oh, Sanjeev, you've got a hand up.
Yeah, just a question, and because I'm pretty sure we are not the only ones who are implementing patient summary first. There are examples from all over the world. I mean, are these being taken into consideration? I'm guessing they are, but is that something that can be shared as well, rather than trying to reinvent the wheel? Also learn from how it has been done. I know ours is a unique scenario, of course, but still might be relevant as well.
The actual, like our actual IG, yeah, like all our designs and are we going to support particular operations? That's really closely tied. And
I'm thinking more like how it was implemented, rather than from a technical perspective, more from a functional perspective, use case perspective.
So there's a couple of things in response to that. I think we're looking at trying to organize potentially even a webinar from what have people actually done around the world to get some of that feedback for us. And it's good that you're interested because that tells us to keep going. The other part is I would love to see some detailed documentation of use cases in their FHIR IGs, but I haven't seen it. And I really think that's missing. I'm really pleased around what we've done with the consumer journeys and that kind of content, because I've not actually seen that be available. And I think that's a really big gap in helping people understand, okay, there's an AU CDI that covers patient summary and there's a FHIR IG. That's great. But, you know, how does that actually work?
Yeah, absolutely.
So we're leading the way.
Okay, so I might count down then. We'll go 5, 4, 3, 2, and 1. And so that was my last Menti. So I might go back to you, Danielle.
Okay, I'll start sharing my screen. Okay, so I think that tells us the first draft that gets worked on, because we only had some minor call outs for those things, is having a crack at all of these when it's drafted and then bringing it back and going, well, is this working? Do we need to add more stuff? Yeah. Okay, cool.
Yep. Okay. So at this point, now that we've got the Menti results, I'd like to ask if anyone has any concerns with us proceeding with this approach. So if everyone's happy, I'd like to propose a motion to accept the proposed approach for including use cases into the AU Patient Summary FHIR IG.
Thanks, Shelley. We have a motion. Is there a seconder?
This is Philip Lawyer. I'm happy to second.
Thanks, Philip. I will now put up the electronic poll. Are there any other comments or questions while I'm finding that? Okay, you should start seeing that that electronic poll. Please vote affirmative if you're happy for us to proceed on the in-principle approach. Negative if you'd like us to look at revising one of these or adding an additional step at this point, or abstain if you don't care or aren't sure you can make a decision at this time. All right, just waiting for a few more people to vote here. If you can't vote, obviously you can put that in the chat, but if you have dialed in, you can say your name and whether you are affirmative, negative, or abstain. I'll now count that down in 5, 4, 3, 2, 1. I will end that poll. And now I'm looking at the chat, so I've got your Steve. Who's FHIR work group?
No, you can get off mute. It's Brett here.
Brett.
Okay. Thanks, Brett. Could you change your name?
Yeah,
That will
okay.
help us with attendees.
That's my name now.
Brett's
It's
the
easier to
entire
change my actual name.
group.
Yeah. Yeah.
Okay, that's great.
Cheers.
And I see that from Tim. So with the 3 votes in the chat, the affirmative is 28, the negative is 0, the abstain is 4. I would also like to note for the minutes there that when this content is progressed for the first time, taking into account what Stephen has raised about the best way for us to go forwards, we should also revisit the discussion on if, you know, there's any, if we can look at using Confluence or if that could help at a certain point, and we can discuss that there.
Lovely.
Okay, thanks, Shelley. Next slide.
Okay, so next steps. So what we'll do now that we've got agreement on our approach, we're going to go away and we'll start populating the AU Patient Summary IG based on our initial agreements. Then we're going to come back at our next meeting on the 18th of March, which is going to be a hybrid meeting that's held in conjunction with the Connectathon. And there we might look at which parts of the use cases we want to work on for R1. So, you know, from each of those use cases, which bits of that are we going to work on? Because they are quite detailed and we can't do the whole thing all at once. From there, we're going to start exploring the implementation of the use cases at the Connectathon. Then at our next meeting on the 4th of April, we're going to start bringing some of those use case design decisions to the TGG group for discussion and agreement. So, you know, come prepared for some robust discussions. And then once we make those initial decisions, we'll go away and start updating the FHIR IG again with the outcomes of those decisions. And then we're going to do that all over again at our next meeting on the 18th of April. So we'll come back to you guys with some more use case design decisions for you to have a look at, discuss and agree upon. And then that process will continue again with us taking those away and updating the FHIR IG again. So lots of things coming up for you guys to have your say on, and yeah, looking forward to doing that with you.
Thanks, Shelley.
Thanks, guys.
Okay, so Adelaide report back. Over to you, Steve.
Yep, thank you. Could you just go to the, yep, great, thanks. Okay, so report back from the workshop that we held a couple of weeks ago. So yesterday I actually did the report back for the medications in AU Core R2 portion. That was the first quarter of the workshop, so I'm not going to go through that again. But in this one, I'll be going through the medications in Patient Summary and also the exchange considerations and architecture workshops that we had. So we had around 80 attendees on the day, a mix of clinical and technical people, and also 4 amazing vendor demos, really putting that the medications and the patient summary really into context. And then we did a couple of workshops on system roles in patient summary, what medication resources should be supported by each of those roles. There was a workshop on considerations for the referral consumer journey, and then a workshop on exchange architecture. So the first workshop we did was around the patient medications in patient summary. We came up with a few roles in Patient Summary. This is not an official list. These are roles that have been discussed in the Patient Summary community, but they are some roles that we've identified as being participants of exchanging patient summaries. And what we wanted to understand here was what roles needed what medication data, and whether it's one or both of medication request and or medication statement, and then noting the IPS version 2 rules, which we're working towards. So those rules are around in the medication summary section for the patient summary, that there must be either no entry indicating that the medications are unknown, an entry indicating that there's no meds, or one or more entries that may be medication request or medication statement. So what we wanted to understand through this workshop was what should be populated in the AU patient summary medication summary section. Is it one or both, and why? And so if we go to the next slide. Yep. So here's our results. So not every table filled in every role, which is why we have some different totals there. We had 15 or so tables, but overall, the majority agreed that we needed to support both. The requester and generator results there are interesting. In the comments that we're about to get into, the actual written comments, there were some different use cases indicated. So I guess in terms of the requester, request what you need. You may not necessarily need to support both. And the generator, well, you would generate what you're asked for. So again, you may not need to support both, but there was quite a lot of responses around actually generating both. The responder, the viewer, and the exchanger makes sense in that you would need to be able to handle both for viewing or responding or exchanging data. But I'd like to just pause and just ask, have you got any comments on these results? Is this different to what you expected? If you were there on the day, do you have any views? And then we'll get into the comments that people had on the actual worksheets themselves. No? Okay. So we'll move on to the next slide, please. Yep, great. So the key takeaways from that patient medications in patient summary workshop were that really both may be required for a complete clinical picture. So medication statement reflects the medications taken, while medication request represents generally prescriptions issued, but potentially not yet dispensed. So there could be some sort of gap there. And so both really are required for that complete clinical picture. Different stakeholders need different access. So clinicians may need both for clinical decision-making. Patients may not really need access to medication requests, but pharmacists would rely on medication requests for dispensing and then looking at the medication statements for medication history. So we've got a wide view of use cases needing one or both, or potentially even both across each of those different roles for using the patient summary. Ensuring completeness was another key theme. So systems generating the patient summary should really be including pending prescriptions to prevent any sort of missing data, and avoiding duplication. So medication statements should not straight up duplicate medication requests, but they should be linked. So that was one of the feedback items that we got. The other pieces of information that we got around historical data. So past medications should be available for pharmacovigilance, for audits, and also patient history tracking. And then a bunch of info around system roles and access control. So requesters need to track who's making the requests and responding to the requests. Responders and viewers need controlled access to prevent unauthorized changes, and a lot of things around consent and also the security of the record. But I guess the summary here is that nearly all types of roles need both types of data, but without duplicating them. Next slide, please. Yep. Okay, so in workshop 3, we talked about patient summary exchange considerations, and we walked through the referral to specialist and allied health consumer journey. This was the consumer journey that became evident after talking to a number of the vendors in the lead up to the workshop. That was really the one that stood out as being probably the first one off the bat for us to work through. So we walked through some of the steps, and we did a worksheet and a table activity. And so we split up the tables. So 1/3 of each of the tables each took on one of the 3 steps. So the first step was around referral creation. And this is about the referral being created and then the patient summary also being created at the same time. So the key takeaways here is that around interoperability and secure data transmission, again, around consent and privacy, and then also the necessity of a patient summary within a referral, making sure that the correct information or the required information is available for that particular referral, and you're not giving too much information away. And then also technical solutions. So the payload of the patient summary within the referral, or is it a reference with a link? And I guess some issues around security and usability and efficiency of actually retrieving that referral when it's received. And so that takes us to the next step of the consumer journey, which is that referral being received. So again, here, the takeaways are around security, ensuring the referral completeness. So validating some of that information around dates and supporting information. Any changes between patient status. So when the referral is created and when the referral is triaged, there may have been a change in circumstance with the patient. So making sure that that information is available. Again, we've got authorization and authentication, and then secure transmission. So avoiding email and fax. And then the mechanism to fetch the most recent patient summary. So this particular step talks about the retrieval of the patient summary at the time the referral was created. And also the next step actually talks about the most recent patient summary. So there were some comments here around how do we actually access the patient summary? Is it a QR code? Is it a link? And then also an interesting comment there around tracking that the referral's actually been received. So some good feedback there. There's a link at the bottom of these slides to the worksheets. And so all of the comments and all of the ticks and crosses on the sheets, they've all been transcribed. So you can have a look at all the raw data that's there. On to step 3. Yep. So this one was around the referral actually being triaged. So interestingly here, a lot of the discussion was around the triage itself rather than the methods for actually retrieving the patient summary, but we do need to work through that. So that's something we're going to be talking about in upcoming calls and workshops as we determine some guidance around the technical implementation. And I guess the key takeaways here is that we need full and correct information, needs to be up to date, and also how do we migrate data from receiving the patient summary into our own system that's viewing it. Next one. So overall, the consumer journeys, the feedback was that the consumer journeys are really good for capturing the scenarios and the workflows. There's a lot of complexity in it and a lot of things that we need to actually consider. And that's exactly what we're going to be doing as we work through this patient summary use case exercise that Shelley was talking about, defining those operations, how we expect patient summaries to be exchanged, and providing some guidance around that. Okay, dokie, next slide. Overall, people found the session really engaging, educational and collaborative. but also very information dense, which it was because we were trying to rip through quite a lot of information. So we are going to now talk about some of the exchange considerations, and I'll hand over, sorry, the exchange architecture, and I'll hand over to Heath.
Thank you. So this is a session that I did at the end of the day in Adelaide after 2.5 days of sessions. So it was something that we skipped through pretty quickly, and probably was one of the causes for that overall feedback of being information dense and stuff like that. But we've had a very different audience to a lot of the TDG calls that we have in Adelaide, where we actually had quite a lot of clinicians that were stayed over from the day before, etc. So we thought we'd replay this session to this audience so that we could get your feedback as well. So what I just want to do first is give you a bit of a summary of some of the exploration that I've done around what is happening in IPS projects around the world. And in Adelaide, Graham gave his perspective of it, having actually travelled and discussed these projects with a number of people. But one of the most interesting ones is the IPS for pilgrimage, which I kind of referenced earlier in the chat, which is about Hague pilgrims that migrate to Saudi Arabia on an annual basis. And there's millions of people that come into the Mecca for this religious event, which are often quite old, underprivileged and unhealthy. And they're crossing boundaries, and if they need healthcare whilst in Saudi Arabia, they needed to have at least a vaccination, and obviously this is post-COVID, etc. So this particular project focused on vaccination, but it has the opportunity to grow greater than that because it's based on IPS. Initially, just to give you an example of this was actually built very quickly back in, I'm not sure if it was actually for the 2024 Hague, but there was 3 countries involved, Malaysia, Indonesia and Oman, and they issued 250,000 healthcare cards for that particular pilgrimage. And so it was a really good example of people quickly implementing IPS and as effectively a health card on people's phones, so that they were able to retrieve informed healthcare when they were in another country. Then there's the LAC Pass Latin American project, which is actually a collaborative. There's a lot of countries that are implementing IPS independently: Brazil, Argentina, and Chile. They're all got their own implementation guides, but this is a collaboration of trying to pull those together again to go across countries. And it is actually also based on the WHO pilgrimage model, focusing again on vaccinations as a starting point, and that they intend to extend that further out. Canada has got a very large project going on through their Canada Health Infirmary. They've basically fully defined an IPS with most of the sections in line. It's based on their on their Canadian core profiles, and they have actually defined two different options for patient summary exchange, so as well. WA, which is Washington State. So again, this was based on around vaccinations initially, but and literally just as a vaccination record on your phone. So it was actually as a health card, but they're starting to grow that out into an IPS mechanism as well, going beyond that. So, and obviously IPS is being more much larger documents. They needed to look at alternate ways of carrying access to that IPS, and hence they've moved from things like smart health cards through to using smart health links. For those that have got some understanding around that. But again, they're going cross borders now, across state borders, but obviously, as we probably know around United States, they're not overly united. They actually like little countries, but also across to the Canadian border because of its particular location. Switzerland is quite advanced in their IPS work, but then that's growing into a more general European piece of work. So I think that the HL7 working group meeting in Spain in May is going to actually have quite a considerable interest around the patient summary work in Europe in May. So next slide. So what I wanted to just do now is look
And
at
Heath,
Yeah.
I'll give you a time. You've got 17 minutes.
Sure. So I just wanted to this will be a whirlwind, but I just wanted to give you a summary of what some of the possible approaches to exchanging patient summaries based on a review of these various projects that are going on around the world. So the IPS profile itself is specifies a patient dollar summary operation. So that's on the patient endpoint dollar summary. In order for you to be able to generate a IPS document. And that has a number of implementations in some of the commercial products that are available, open source and commercial products as well, that can be customized around the place. But in general, what it is simply a operation request, and it returns a document bundle as its payload in return generated by the server. This approach is being used by the Washington State Verify Plus project as basically the URL that is being encoded by the Smart Health link. Next slide. Just go back, yes, so that last point there, the key point here is that the IPS document is not persisted on the server. It is literally generated and then up to the receiver to do what it will with it from there. Next slide is about document reference $.ref. So it's on the document reference endpoint, another operation. Now this is got a number of parameters on it: patient start, end, dates, document types, profiles, and one in particular of on demand. So this is a very generic operation. It can be used for all sorts of different purposes, including not just returning via patient summary documents, but any document reference, any PDF, CDA documents, etc. So it's extremely generic and really needs to be profiled in the context of your particular implementation. It returns a search responsive bundle with a list of documents. So basically what you can return is many documents that satisfy that particular set of requirements. But if you don't specify anything other than a patient ID in the document, it will revert to returning a patient summary document. Now that patient summary document may be something that is stored, already existing, or it could be actually auto-generated. It may be a CDA document, it may be a PDF, it may be a FHIR bundle. Hence the need for profiling. Next slide. I think I've said that already. Got the ability to just go back a step. The key one is that bold one there, which is on demand generated document reference may be persisted. So you might ask for it to be generated on demand, but the server may choose to actually persist it so that it could actually then retrieve that again for a later purpose. whether that is using the $.docref operation again or using search and read requests. Okay. Any questions on that particular one? That it was quite a complex operation. Okay. Moving on.
Yes, sorry, just to clarify. So if I would like to persist IPS bundle, I should create like a related document reference and refer to this state of IPS or IUPS.
Let's take that one off line, but basically this operation will return existing documents, however they got created, or if you choose to, it can actually be auto-generated. So
There's a
it's
note
one
to
or the
that
other.
that I've put in the chat that whether or not a client can signal they want on demand, but the server is not obligated to do that. That's up to them on whether or not their response is to trigger that. If they receive it, they can return an existing resource.
Yeah, but also the server can create on demand without it being asked to.
That's right. So it's all about server implementation.
Yep.
The $.docref operation defines the expected behavior of that, including that, that's essentially the client is saying, here's what I'd like to request. And then it's up to what that server has implemented and how as to what is returned.
It's basically a whole toolbox in one operation. Okay, next slide. Sorry, just that docref is defined in the IPA specification, by the way, and is referenced from the IPS specification. So the next set of or option is basically a standard FHIR operations. So, or interactions. So starting with basically document bundles. So as you may know that basically a bundle has multiple types. You can use them for search responses. You can use them for transactions. You can use them as a message. You can also use them as a document. And that, in the context of patient summary, that is the bundle type that we are using to compose patient summaries. So once you've composed a document summary as a bundle of type document, you can then store that in a server using the create interaction on the bundle endpoint. And as a result of that, you can do search and reads using the standard definitions or search parameters, etc., specified by FHIR. This is one of those options that the Canadian Patient Summary Project uses, and it is also quite commonly used as part of Smart Health Links to simply retrieve a generated bundle of a patient summary. So the URL in the health link is the actual bundle URL itself. So next one is around document reference interactions to actually provide you some metadata. So you still create the document bundle, but then you create a document reference. And hopefully this addresses your point, Ilya, if I understood it correctly. Otherwise, we can talk about it later. That basically it's that combination of create. So create the document, patient summary document, and then you also create the document reference that points to it. It provides the metadata about that document independently. And that's really intended for discovery purposes. And it's treated, again, going back to the docref, basically any document, whether it's a PDF, a CDA, or a patient a bundle document, is treated in a very similar manner. And it's just a URL to that document bundle that's encoded in the document reference. So you do your search against the document reference, and then you basically do your read on the bundle because it's the URL in the document reference returned. Next. So this is actually the approach that's used quite commonly in the IPS pilgrimage project. LAC Pass is using it, and it's the second option that the Canadians provide for exchanging their patient summaries. So just go back a slide. Is there any other options or discussion on that, or other options that people feel have been kind of missed from that list? Not for today. Okay.
You can raise them at future points,
Yeah.
and you have
Moving on then.
8 minutes.
So just tying this back to what the patient journey, we've got the referral creation step here, where we're wanting to create a patient summary to support that referral. So if you can just go to the next one. So these are obviously your generate provide sort of interactions. So the options in basically I've presented are the dollar summary. We could use a doc ref. We could do a bundle create. We could do a document reference create. And then as we move down to the referral received, and also the referral triage as well, we're looking to retrieve them. Now, the difference between these is one is that it is the specific document patient summary associated with at the time of the referral that we want to retrieve, versus the second one, which is getting the latest patient summary. So if we can skip across to the Minty again, same Minty. Did you want to share, Shelley, if you've still got that running?
Yep. Has everyone had enough time to get the, oh, they've probably got the QR code already.
I'll stop sharing in 5, 4, 3. Oh, I think I might have stopped sharing. Yes, perfect.
Hopefully everyone can see that.
No. Yep.
Yep. Lovely. All right.
Okay, so the first Minty is to just get a bit of a sense of, no, it's a bit of a whirlwind, but if you've got some existing implementations, or you've been thinking about this already in the context of providing a supporting patient summary with a referral, which interaction or an exchange option are you thinking that you would like? And if you don't know, just abstain using don't know.
Can we also, I guess, qualify that the series of mentees that we put up will be one in the context of referral, and then one in a wider context. So it won't be limited to referral. This one is asking specifically within a referral context.
So it's slowed down, Shelley.
I think so.
One more.
Last couple.
So dollar summary is getting a pretty high score. A few on docref.
I reckon next time we might also do a I'm not doing referrals option.
Just very quickly, if the person that said other, do they want to suggest what that other might be? Moving forward.
Yep.
So this is the more general question about, from a TDG perspective, what do we need to agree on in relation to generation or providing a patient summary? So open question here. Hopefully it's multiple responses. So the operation to use is what we're trying to work through. Yes, patient consent is something that needs to be worked through. Profiling, we're definitely working on that already.
Can we qualify the we here? Because there's a bit between this group, and this group isn't going to be defining national consent rules. And then there's the we that is the we that are working on actually providing patient summaries. And I guess Australia level. So there's a lot of we's that could be relevant.
And I guess in the context, as I indicated, in the context of this TDG group, so to be in the to get a implementation guide so that vendors, members of this TDG, can implement.
Mhm.
There's certainly things in that, you know, we're not able to solve. There's bigger questions and bigger programs going on around. Okay, so I think that's okay. One more. Still going. All right, we might count down 1, 2, 3, and we'll stop it at that. So next question is going to be around retrieval of the supporting patient summary when we receive the referral. So what are the retrieval mechanisms that we're going to use? And this may be a quick trick question in some frame, but we'll see how we go, because we do want to make sure that we're getting that patient summary that was provided or as part of the referral process.
What does it mean here, like document reference search? Because basically, for me, document $doc and document reference search, they're pretty the same.
They
So,
are, except that there is the auto generation approach to it. All right, so
The $doc
they're
ref is
not.
an operation though with multiple different parameters. Document reference search is the same as search on any kind of resource. Like it's a flat search for a very
So
yeah,
doc,
so like the idea is that to use generic FHIR search over a specific docref operation. So it's the difference between these two options.
the generation or the auto generation is the difference between the two operations. The result is the same.
Not necessarily. I mean, so for example, let's say this is the link thing. And let's say what's actually embedded is a business identifier. You could do document ref search on, which would almost be document ref get, actually, get me the thing with this ID. You wouldn't need to call $doc if you are undertaking an agreed workflow where you've got a persistent identifier that you can track through into a clinical system. But $doc is really quite crucial when you know patient information, for example, and you don't necessarily know about how the other system reacts. I think there's just some flexibility with $doc, but when you've got certainties, your search ones are probably cheaper and easier to do.
Absolutely. Yep. Okay, moving forward, more generally, as a TDG, what do we need to agree on around retrieval of an existing patient summary? We'll try and speed this one up a little bit. So if you've got something that you desperately want to share with us. Okay, so I might close that one down.
Hang on. Again, I'm not, I can't
Sorry,
that
I'm
fast.
writing.
Slow down then. Yeah, when it's these long text fields, especially on a mobile phone, I'm a touch typer, but on my phone, it's slow. And look, I made a spelling mistake. That first one's me. It's meant to be options, not options.
There's 3 spelling mistakes. What happened to autocorrect?
We know what you mean.
Good. I'm glad you do.
All right, we might close that one down now. All right, moving on. Now we're actually talking about retrieving the most recent patient summary. So the dollar summary is heavily favored in this one, which is not surprising. and verifies what we had in Adelaide. Okay, thank you. So I think that's settled. And again, our general question around the retrieval of the most recent patient summary, what do we need to agree on?
We might need to stop there unless there are any other crucial ones, because we're about 3 minutes away from closure of the meeting.
I think that's fair enough. We got what we wanted. Let's do that.
All right. Thank you very much, Heath, and everyone else for responding. Let's just finish with what's next. Can everyone see my screen now?
Mhm.
Fantastic. Okay, so just a quick wrap up. What's next? There is, if you want to come to that, an information session on dosage. That's in Zulip and it's posted in the FHIR calendar. That's going to be all around dosage. How does it work in FHIR? What's AU Core thinking of doing, basically? So if you want to come to that, feel free. You can bring your own cases and how does it work and have a bunch of questions. Then we've got our workgroup symposium day where we have a call, which is a hybrid, some of which I'll see you in person, I hope. And then the Connectathon, we're going to be working through a number of the different patient summary test scenarios around viewing and generating. There's a track kickoff call later today for that. And then we've got a couple of calls where we're going to be going through both any specification feedback we're getting through already, where people want to suggest changes to the IG, especially things coming out of Connectathon or testing. And also we're going to have a look through the use case designs decisions that Shelley has called out, along with, I guess, starting to progress what we just flagged on talking about our exchange options. How do they work? Is there any localization we need in Australia? So that's, I think, really what's coming up. So here's the details. Next meeting, remember, it's a different time. You should have it in your calendars. And this time it's Microsoft Teams. So it's not Zoom. This is the time there. We're going through this kind of set of content. Is there anything people want to add to that agenda besides usual business, picking up that use case content and making some decisions? Talking about Connectathon and testing. Anything else for this next call? All right. If you have something that you think is a burning question, we need to get to it in the next meeting, can you email me or contact me on Zulip? So that's chat.fire.org and we can add that to that agenda. Oh, reminder, there's a Zulip poll on dosage. And I think that brings us to the end of the meeting on time. That's amazing. Any other comments or questions before we wrap up? All right. Thanks, everyone. Thanks, Heath, for running through that again in this call. I think that was really interesting. And I'd like to discuss, I think, more of those options in detail in these kind of calls in the next things that we've got coming up. All right. Thanks, everyone. I hope to see you in person in Sydney. And if not, see you online.
Thank you.
Thank you.
Thank you.
Yeah.
Have a nice weekend. Bye bye.
Thank you.
Thanks all.
Thank you.